This next case is a 46-year-old man with a history of Behçet's disease and acute recurrent pancreatitis who was transferred with recent acute pancreatitis. CT scan demonstrated a 6-centimeter fluid collection near the tail, as well as splenic vein thrombosis, gastric varices, splenic artery pseudoaneurysm. A subsequent CT angiography was performed and confirmed a 12-millimeter pseudoaneurysm of splenic artery branch causing intermittent hemorrhage into the pseudocyst. IR embolization of the aneurysm was successfully performed on the 31st of October, and the patient has now been referred for consideration of endoscopic drainage. On this CT scan, you can see the pseudoaneurysm. Let's go to the room.
Guys, thanks for the case introduction. So you see from the history, this is a pretty complex case. This is something we touched on for those of you who had the chance to come to our Axio Symposium in terms of patient selection. So this guy was initially referred to us about a week ago, and then we identified that splenic aneurysm and some development of blood products. So obviously we deferred on doing the endoscopic drainage, and we asked our IR colleagues to embolize the aneurysm, and you can see it quite nicely on those CT images. I'm just going to walk through the ultrasound, and then we'll go through the diagnostic exam. I think it's important that we cover these bases, and then I'm going to actually put it to the panel and open it up and see what we want to do. So I'm in the bulb here, and this is just a quick review for our diagnostic ultrasound. So we have our bulb view here. Put on Doppler to confirm for us. There's our portal vein coming down to our portal confluence. Very nicely, we see it there. And of course, in the middle of the screen, we have our main pancreatic duct. Now, this guy carries a diagnosis of idiopathic recurrent pancreatitis, documented multiple episodes over the last several years. They did the standard workup, have not found an etiology. So there's the head of our pancreas. For the endosonographers in the room, you can see that we have some hypercoax stranding, almost some subtle lobularity developing here, but no duct dilation. This can oftentimes just be seen with resolving acute pancreatitis, chronic pancreatitis, and sometimes even with autoimmune pancreatitis, we get that very dark, hypoechoic, lobular-looking pancreas. So we're just running through the head of the pancreas here and taking a look like that. As I pull back a little bit and relax my up-down dial, we should see our bile duct superior to the portal vein, and here we go. Put the Doppler on to confirm, and we take our nice picture. The bile duct is not dilated. We can measure that. Just for confirmation. So 4-millimeter bile duct in a roughly 40-year-old male, so that's about right. Again, as we swivel back and forth, we can kind of follow it down. You can see it almost narrows as it enters the neck of the pancreas there, but we get a pretty good look, and we don't see any sludge in the duct to suggest any problems there. Okay, almost maybe something there as we're coming up. But I don't think that's actually intraductular there. And then as we come up towards the liver hilum, we can follow it up. And as Dr. Minoller described, looking to see if we can find the common hepatic duct and where the cystic duct takeoff arises from. A little bit difficult in him in this bulb view. See a lymph node here as well, inflammatory lymph node, which he has a right to have. I'm going to pull back just a bit so I can get a better view of the gallbladder. We can see it either by torquing through the bulb or by pulling back into the antrum. And again, hopefully this transmits well, but what we're starting to see here is a little bit of a starry sky kind of pattern, little twinkle. And that, to me, looks like floating sludge within the gallbladder. We can also kind of press on his abdomen and see if we can get a little snow globe effect and see how it swirls. And you see how that moves like that? So that would be indicative of some gallbladder sludge. And the question is now, is this the chicken or the egg? Is the sludge the cause of his recurrent acute pancreatitis, or has he been in the hospital? He's been in the hospital, I think, 3 times in the last 2 months, NPO and so forth, and critically ill. Now, is this just an epiphenomenon of him being NPO and sick in the hospital? So that's the big question. I think, given the fact that we haven't found another etiology, I think it'd be reasonable for him to undergo an elective cholecystectomy for that sludge. So that's sort of our bulb antral view. I'm going to start pulling back on the scope, and we're going to try and follow our pancreas. And here we still see it at right underneath the transducer here. I'll zoom in a little bit. This is still pancreas. And we're going to follow that as I torque clockwise back. You can kind of catch a glimpse of the pancreatic duct there in the neck. Again, not very dilated, very diminutive duct coming through here. right through there. And then as we come back more, I'm pulling back gently on the scope and also continuing my torque, and we can kind of just see how that duct sort of rides over that portal confluence. And then we kind of head back towards the body here. Again, the duct's a little irregular, but otherwise non-dilated. Now, we know that this guy carries a diagnosis of a splenic vein thrombosis, but I think it's also important to recognize that endosonographically. So here's our portal confluence right here, and here's our portal vein, and we can use Doppler again to convince ourselves, and then it splits off into our SMV and splenic vein. And as we continue along the body of the pancreas, we come back here and we can see our vein, and it gets very diminutive out here, very small caliber, right? And we continue to follow back. And I can't say that I see a thrombosis per se, but certainly there's a fairly significant compression of the vessel. It certainly could lead to sinistral hypertension here. Okay, so we recognize that. We're coming back towards the tail. Again, we're anticipating we're going to see our pseudocyst. We're getting excited here. And as we come back, and now you can see really a fair amount of lobularity too to the pancreas as we head out back towards the tail. All right? So now I'm way out towards the tail. I'm going to pull back on our scope, and we're starting to see that anechoic structure deep to us there. Now we see our pseudocyst or walled-off necrosis, and I'm just going to adjust the scope, and here we have our view. So there it comes into view here. A couple of things to note. So number one, we're looking within the cyst itself. We can see hypoechoic debris basically filling up the cyst cavity. That's number one. We're also looking at the deeper level here, and we see this structure here, right? So it almost looks like a mucin ball in a mucinous cyst, right? We have this hyperechoic rim, essentially anechoic center, and then we have this hyperechoic structure here. So that's actually our aneurysm with the embolization coil that IR had placed, right? So now we can see and appreciate that well. The other things to keep in mind when we're looking at our cyst now is, what do the walls look like? Is this cyst mature? And we've discussed this last night. Traditionally, we like to see a mature cyst, a thick-walled cyst, usually wait at least 3 to 4 weeks. There is data that you can go in sooner if you need to, but ideally, I think most of us would agree we'd like to see a nice mature wall. In this instance, the wall's a little bit irregular here, and if we look at the deep border, again, they're almost maybe a little isthmus to a second cyst, but we don't really see it. We just see sort of a shagginess to the deep border, for lack of a better word. So that could be of concern. This cyst has been diagnosed for at least a month, so we know that, generally speaking, this should be mature. But again, something to note. Okay? So as we look at the cyst, we're going to measure it out and assess whether it's actually amenable to drainage. Okay, so we'll just do a quick measurement here. So on the smaller side for transgastric drainage, but certainly feasible to do. I think it sounds like we're going to switch over to the other room.